Hi, everybody, and welcome to another in our series of discussions with our colleagues across the country about the impact of COVID and the nursing informatics world. Today, I am thrilled to have with me Emily Barey and Gregg Springan from Epic, and they're going to talk about the Epic perspective on this whole incredible experience that we're all going through. So just to set the stage, would y'all kind of give me an idea of what the big picture is there at Epic?
Sure. So thanks for having us, Cheryl. One quick housekeeping item, we just wanted to remind the audience that everything we're talking about today is available on our user web and our community library, and our customers, I think, are sharing lots of ideas and content also through ANIA more publicly. So hopefully anything that's shared today is accessible, and we'll continue to kind of promote that in our customer group. But certainly the big picture from our perspective is really kind of interesting in that, on the one hand, we have customers at the epicenter, so organizations in New York and Washington and California. And then we have customers where it's business as usual. And they may be thinking about preparing, they may be ready to respond, but have not found themselves in a surge, so to speak. So that spectrum is really remarkable, and you don't hear that in the news so much, but really important to understand that the whole country is at the ready, but not everybody is feeling it the same way. And this wave of the surge, and being such a big country, I think we're going to expect it for much longer maybe than people realize. I think the other big picture item I would share is we want to acknowledge that our customers are doing an amazing job trying to maintain the standard of care under extraordinary constraints. And it's amazing to see nursing really stepping up, and nursing informatics stepping up to creatively think about ways to take care of patients to the full standard of care, but also ways to reduce the documentation burden, preserve the PPE, keep nurses safe, but it's always still with this guiding principle of doing the best we can for the patient first, kind of regardless of the circumstance. And so that's been really impressive, I think. And then last would be, from my perspective, I was telling Gregg yesterday as we were preparing for this that it feels like the biggest world's go live ever, but it also feels like it's combined with trying to land Apollo 13, like all in one event. It's just that sense of urgency, that sense of having to rapidly triage and be creative and on your toes about clinical care and workflow. But it's probably the single biggest thing our customers have done, or that we've responded to, and amazing to do it on a global level. So we're hoping that today in our conversation, we can offer some things to think about for groups that are, right in the middle of it, but also groups who may be still preparing as well.
Super, thanks. Gregg, anything in this particular category?
I think she's got it covered from a high level.
I do. And I have to say, through the interviews I've been doing over the last couple of days, one of the big words that's coming to my mind when I'm thinking about this is flexibility and adaptability as well. I mean, people are just doing some things that I just was like, wow, what a brilliant idea.
Yeah.
So maybe let's kind of focus on the bedside. What is Epic doing? You mentioned PPE, you mentioned reduced documentation. Could you talk a little bit more about that?
Sure.
Yeah, absolutely. I think, as Emily mentioned, we've been working with groups now. We kind of started a little bit of our epidemic preparedness work groups and daily meetings here at Epic. I think it's been over a month ago now. And I think from the very early time, PPE and reducing documentation were two really key strategies that most organizations kind of realized that they needed to undertake. Had the opportunity to watch your interview with Dr. Sangstack and Karen Huggerts from Vanderbilt, and they were one of the kind of pilot organizations, I would say. We took some recommendations from their standard operating procedure. On the PPE front, I would say one kind of other exemplar comes out of Eisenhower Health in Rancho Mirage, California. It was fairly early on that we kind of heard from their CNIO, Annette, that they had instituted a bit more of a team-based process whereby to conserve PPE, they had pharmacists within their organization working with nursing informatics and nursing leadership to bundle care together, following logic that most nurses know, medications with meals and before bed. But it kind of turned into all care with meals and before bed. So they had pharmacists looking at the medication profiles for patients and trying to organize as much as they could when it's appropriate, medication due times into logical administration times. And what that allowed their nursing staff to do was then have a nurse and a patient care tech enter into a COVID positive patient's room and complete medication administration, complete assessments, get the patient their meal, and do any additional daily cares, bathing, whatever else they might need to do. But it was kind of a little bit of a unique process. Bundled care isn't something that's brand new to nursing literature. It's been around for a while. But this is kind of the first idea of using it as part of a pandemic or as part of a PPE conservation process. That was one kind of key exemplar, I think, that we've seen from across the EPIC community. We wrote up kind of what they did and made some recommendations to the rest of the community that it might be something that you want to take advantage of or at least think about doing. As I mentioned, Vanderbilt was a great exemplar on reducing the documentation. We are seeing this across the community, though. I think, everybody kind of recognizes that clinicians are under a tremendous amount of burden at this point, cognitive burden, and they bring it from home. They're worried about their own safety, but they're showing up to do the work that they have always done. Bonnie Adrian at University of Colorado Health is another great example of working with legal, risk, and compliance folks to make sure that their interpretations of rules and regulations align with the standard operating procedure. Again, not shifting their standard of care, but reducing the subset of documentation that nurses are doing. Kathy Boyle, the Chief Nursing Officer at Denver Health, is another great example of starting to pull together a nurse executive committee to make some decisions on how they're going to pivot. And I think that those are the two things from kind of protecting patients and protecting nurses. But we all know that nurses take care of patients and families. Emily, do you want to talk a little bit about what we're doing on the front of kind of patient and family communication and care together?
Yeah, sure. I think, Cheryl, that's been one of the things that is so stressful for patients, family, and the nurse alike. The nurse is very aware that being without your support network, being out without your loved ones just makes anything harder, particularly under these types of circumstances. So we've had a tool for a long time that enabled communication from the patient to the care team and back in an inpatient and outpatient setting. But one of the things that we're releasing this week, early next week, is the ability to text family right from the patient list, right from the census, essentially, so that you could give a real-time update just a click away from your assignment to the family. And we're hoping that that will improve communication and really engage the family, because they're just, so desperate for information, and the nurses want to give it to them. So we're hoping that that'll just make it really easy, a click away in your workflow to be able to do that. But there again, that was born out of the ingenuity of nurses just using their plain old phones to text family. And sort of saying, well, how could we make that easier, more reliable, and just a standard part of the workflow? I don't know if you read the same article I did in grad school about it only takes a nurse 7 seconds to find a workaround. And actually, right now, I'm extraordinarily glad that it only takes 7 seconds for them to find a workaround, because it's those type of ideas that, as soon as they hit our radar, we can can scale, we can do something about. So I'm hoping this kind of a forum too will just, you know, flood those ideas in through ANIA and the crowdsourcing. And that's what our developers love to do. And I think the informaticists are, as usual, the translators between that great idea and observing it at the bedside and then bringing it to scale, you know, and bringing it into a workflow. So that's been pretty neat to see too, that all those skills just, you know, come into play, and organizations and Epic alike are very grateful to have them there.
Yeah, I'm certainly hearing that in my interviews of that quick, okay, we got to make this work. How do we do it?
Yep.
Okay. Make your IV tubing longer.
Yeah.
Use a Bluetooth stethoscope. I just, in really interesting ways. I mean, whoever thought that I would watch a YouTube video on how to hook 4 patients up to a single ventilator?
Yeah. Yeah.
You know, and some people have asked some questions, and I haven't really heard any good answers to that yet. How do you document on all 4 of those patients? Because that's an interesting one, and I don't know if y'all have any answers to that one yet, but I think that's going to be an interesting one.
Gregg is on the vent committee. I'll let you take that one, Gregg.
Yeah, I would say, you know, across our organizations, many organizations have integrated as many devices as they possibly can,
Sure.
whether that's hemodynamic monitors, ventilators, CRT or CVVH machines. You know, if the data can be outbound from the device and sent into Epic, we want to receive it and try and take some of that burden off of the clinicians. At the point where you're using one vent for multiple patients, we kind of stop the idea of integration. There was a publication, it was a joint publication, it was actually published by the Society for Critical Care Medicine with some considerations and a recommendation against using one vent for multiple patients for a variety of reasons. You know, we've definitely taken it to heart. We've consulted with, we have a critical care pulmonary steering board made up of clinicians from the Epic community. And, you know, we've asked them, is this something that we should really address? The immediate response is, no, with the joint statement that's out there, let's just keep moving forward. And we've got a few other problems or issues that we want to tackle, but certainly something that's on our radar.
Yeah, I think the one thing we have seen, Cheryl, though, is in general, the required documentation. So for example, if your normal standard of care was to assess ventilators frequently, obviously, but maybe document every hour, we've seen the requirement, you know, you continue to assess, but maybe you're only documenting every 2 to 4 hours.
Right.
Especially in the scenario where maybe now you are caring for a 1 to 4 ratio as opposed to 1 to 1 or 1 to 2. I know that our groups in New York have already really brought that required documentation down to try to facilitate being able to cover an increased patient care load, but still get some documentation in the chart.
Yeah, you think burden of documentation was a huge issue before this started.
Yeah.
Now it's really, and it's going to be interesting to see where it goes afterward. When we're on the backside of this, how is this going to change a lot of things? At least I think so. So let's take it like, I'm hearing all this about field hospitals and, you know, changing your ORs into ICU rooms, and that whole thing first inside the hospital and then actually outside your 4 walls. Could you talk about that, building that capacity within the facility?
Sure. Our customers, I think, first and foremost, in terms of building capacity, have tried to keep patients out of the hospital. So just reducing the flow to begin with. And we've seen that come in 2 primary ways. One would be really encouraging patients to do self-triage. So to take advantage of the patient portals that you could use either as a patient or even as a guest of the organization. You don't necessarily have to be a known patient to the healthcare organization. But completing that self-triage as a way of then determining, do I make a phone call to come in? Do I sit tight? Do I take some self-care measures? What type of precautions should I be implementing at home? That has been one of the things you might have seen OCHIN did out in the Pacific Northwest very early in Washington and the Seattle area, was to try to engage people in the self-triage to slow the curve, if you will, into the clinics. Then I think the second thing we're seeing is a lot of telehealth. Now, certainly the groups that had programs in place were able to ramp those up more quickly. But even groups that didn't have it in place, we had over 200 customers implement telehealth programs in a matter of a week to try to avoid patients having contact in a clinic or in the emergency department. Now, some of those statistics are just phenomenal. For example, Ochsner in Louisiana said, well, last year we did 3,000 telehealth visits. Yesterday we did 3,000 telehealth visits. So, it's really been exponential. What is neat about it, though, is largely nursing led. It's a team-based model, of course, and seeing the primary care docs really step up and play that backfill to the hospitalists as the hospitalists are backfilling the intensivists. But the nurses are also doing the same thing in terms of being a part of that initial screening call, the initial triaging, and determining whether or not someone should come in, and again, what their care path really should look like. I was also really encouraged by Ochsner's program. They have a text component to their program for those patients who can text symptoms on a daily basis for a check. But they've found that engaging the social work team has also been very helpful, particularly for those patients who may need reassurance, may need information and education, and not necessarily traditional kind of clinical care. They may need resources to be connected to other resources as well while they're trying to self-quarantine. So that was a pretty neat part of their program too, I think, to see how it all comes together as a team. The last thing I would mention, kind of in this spirit of self-triage and telehealth, is it's really brought to light the need of health literacy, or the lack of health literacy in our country, and also the lack of health literacy in the context of technology. We're fortunate, many of our customers have already done a lot of great work in that area, and so ramping it up wasn't very hard, but particularly for those most vulnerable, the questions about screening: do you have access to the internet? Do you have access to a phone with cell service? Are you comfortable filling out an online questionnaire, et cetera, et cetera. I think these are some of the things that we're going to find in the root cause analysis, and likely a role for nursing and nursing informatics to be thinking about, which is that health literacy and technology literacy question as a preventative strategy in the future. Gregg, I know we talked a little bit about capacity building in the hospital, first and foremost, keeping people out as one way of freeing up beds, but other things we're doing, or you're seeing customers do?
Yeah, I would say, Cheryl, you mentioned, converting ORs into ICUs and PACUs into ICUs. And I think short of turning on a switch and making an OR bed an ICU bed in the electronic health record, I think the capacity has really needed to be built within the personnel that you have who are working in those areas. One of the components that's become really important is a quick way to assimilate somebody like an ambulatory care nurse to take care of med-surg patients, or an OR nurse, since all of our ORs are closed for elective cases, and now they're all turned into ICUs. How do we turn those OR nurses into ICU nurses? And it's both a tool set and a little bit of a competency refresher, in that, we have this really tight integration today between practice and technology, and you can't really sever those things if you're a successful organization. They have to walk hand in hand. And so, we've done a little bit of work here. In fact, quite a bit of work on putting forth checklists that organizations can use to quickly get somebody up to speed on what are the new tool set that they need to have. And this was also included a little bit in your conversation with the team from Vanderbilt about, redeploying security and getting people the right tools that they need. So beyond just a bed capacity, it's also, I think, the workforce capacity. The second thing that I would say has become really important for organizations, we talked about vents just a couple of minutes ago, but the idea of tracking assets. Biomed departments have historically been really good at tracking assets and knowing what's within their organization, but knowing where it physically is within that organization or who's connected to which device sometimes can be a bit of a struggle. We have organizations that are actually really successful with this. Johns Hopkins reported earlier this week that because they have every single ventilator as a unique asset, and because they've deployed, again, a bit of a team-based approach, nursing informatics, nursing, and respiratory therapy partnering together and having this be a respiratory therapy-owned process, actually has given them some great insight into not only capacity, how many vents do we have available, but also who's connected to which vent and where, so that they can redeploy them as is needed across the organization. I think one other thing that's become really important in building capacity within the organization is the idea of some sort of a scoring metric. And we see a number of tools being used across organizations, whether that's predictive models, something like a SOFA score, or leveraging in new and creative ways SIR scores. We also have tool sets that are available to organizations using Epic. We have a deterioration index. It's a predictive model that's really built upon some of the industry standards out there. But I think oftentimes what we're seeing now is that that metric actually has a number of different uses, and that while it may have historically been used just as an indicator of clinical deterioration, if and when we get to the point that we're having to make decisions about who gets ventilators versus who gets a lower level of treatment, maybe that's, in the state of New York, that specific metric becomes really important in making sure that teams have a good understanding of what that means to practice, but also what it means for the rest of the team who's using it to deliver care.
I can tell you, Cheryl, that in New York, I've talked with a couple of CNIOs who were reviewing those workflows because they're so dependent on nursing documentation, and the balance there of, well, we want to reduce the nursing documentation burden, but on the other hand, some of what we're collecting is key to drive those metrics and those predictive models, and big decisions are going to be riding on those models, or at least informing those policies and procedures. So it's a key role, I think, for informatics to be at the table for those implementations and discussions.
Yeah, and I would also say it's important for informatics nurses to be out there explaining to the clinicians why that piece of documentation that may not seem important to them in this time actually is extremely important.
Yeah.
Because I find sometimes that's what happens, is the person who's actually doing the work doesn't have a clear understanding of why they're doing that work.
Right.
What's the meaning of it? So, and they may find that workaround. They're like, well, okay, I'll just dump that piece.
Mm-hmm.
Not understanding what they've actually taken away from the entire process.
Right. Or the difference between charting it in a structured way, in a form-based way where we can consume it for the purposes of the model, versus a quick note in a free text where certainly they did their job to document, but then we've missed the opportunity to have it inform some of these models. So absolutely, and I think that's a great place for the informatics team to be educating. The other role I think that we're seeing informatics be really critical on is as a convener. So, educator, of course, and workflow analysis, but also a convener. And in particular, we had the Kaiser Nursing Informatics Group as well as Hopkins and Boston Medical Center, raised the question of decedent affairs. And, naturally, nursing, again, taking care of people birth to death. This may be a workflow that an organization has. They likely don't use it as often as they might need to be using it in the next several weeks. But it was the nurses who convened that conversation, because recognizing how critical that's going to be for families to understand where their loved one is, what type of process, given that sometimes we're waiting for test results to be still pending, maybe there's going to be an evaluation of that. And I think that was also kind of gave me goosebumps when it was raised. I just thought, oh my gosh, how could I forget? And so that's become a big part of what we released this week, as well as a reminder about that workflow, refresher on the tip sheet. But I think that role of convener and bridging, the workflow from the bedside to the morgue to the family communication, that's nursing informatics sweet spot, I think, for an otherwise tough subject.
Absolutely. And unfortunately, we're having so many of those tough subjects right now. I mean, just looking at some of the, I'm former emergency department nurse, so I still am a member of the organization, and I'm looking at a lot of these listservs and these discussions that are just so painful for everybody.
Yeah.
So anything else on that whole capacity or within the facility that y'all want to talk about?
No, I think those are the big ones that we're finding in the four walls. Yeah.
So let's move outside, because I mean, there's tents going up, there's churches being used, there's football stadiums and convention centers. I mean, one of my concerns is, how are we tracking the patients as we move from things to, from place to place to place to place?
Yeah.
So I'd love you to expound on that one a little more.
Greg, do you want to start, or do you think I should start with interoperability?
I would start with interoperability.
Yeah, you mentioned tracking patients place to place to place, and interoperability has just been, I mean, can you imagine where we would be had we not done the last 10 years worth of work to get this country a little bit better wired? So that has been extraordinary. One thing we are finding, though, is at the organization level as well as at the state level, is relaxing the requirements for consent and really trying to reduce the barrier for patient as well as provider or clinician consent to do the exchange. We're seeing that grow, which is a good thing. Just to really let the data flow, so to speak. I think the second thing, of course, is it is the best way to get visibility into the screening status. We did some development to expose that, where they were in the screening process, where they were in the testing process, and then of course the infection status itself being at least visible. Our next step is to try to make that infection status structured in a way that you could consume it in a structured way, and then have it drive additional rules and settings in the system. But you certainly can see it. And I would say from the Javits Center perspective, talking about tents, and Gregg will talk a little bit about this too, they are relying on interoperability to get demographics. I mean, just to get the basics of registration started, let alone a clinical summary. So it really has been just an extraordinary asset right now to keep track of people and make those care coordination handoffs just a little bit more reliable. But I know, Gregg, you've been a little closer to the tents.
Yeah, I would say one of the things beyond the demographic details, what we might have historically thought of as just a printout, a face sheet for that patient, is that across the EPIC community in the last 5 years, we've actually seen a fairly rapid adoption of mobile technology, both inside the four walls of the hospital, but also increasingly outside the four walls of the hospital. And these field hospitals, or the care that's being provided in tents or stadiums or hotels, are increasingly reliant on a mobile device because they may or they may not have the capacity or the infrastructure to get computers or workstations in place. Whether that's a BYOD, bring your own device strategy that some organizations are using to deploy mobile devices, or actually physically deploying an iPhone or an Android smartphone. We have applications for both of those platforms. But this idea of being able to do some quick documentation, focused assessments, and some examples, quick medication administration, if and when it's appropriate, if they're placing orders. I think one thing that's been a bit unique for us is that if you've seen one field hospital, you've only seen one field hospital, and that they're all a little bit different, and how much stays electronic versus how much ends up either being documented on paper. I would say the one thing that remains constant is that registration usually is always completed in the electronic system, because they are using it to track and then exchange something, even if it's as basic as the summary of care record or a clinical summary through interoperability or exchanges between health systems and that endpoint of a field hospital.
Yeah. I think, Cheryl, the other thing related to tracking people has been the transfer of care, and your members may know this, that of course a lot of these field hospitals are being set up even with lower acuity in mind, because the discharged patient can't go home, can't go back to the SNF or the assisted living facility. And because they're still positive technically, so we need an area for them to transition. So we're seeing this range of acuity from very high acuity to lower acuity, providing that transition. And one thing I would just say about home care, SNF, long-term care, et cetera, right now is don't forget about them. I think we keep talking about acute care, and we keep talking about the tents, but what's becoming very obvious is that home care and the rehab centers have been left out of the conversation a bit when it comes to PPE or reduced documentation. Everything we're talking about today actually applies in those settings as well, and our customers are doing that also. So while we've kind of put an inpatient lens to it, it certainly is all applicable to our colleagues who are working in the post-acute setting.
Yeah, and I think that's so critical, Emily, that we're really not hearing much about that, at least in the reporting and things that are on the television and Twitter and every place else that it is now in the world, of those people who can't go home.
Yeah.
Or they come in for a certain amount of care but can't go back somewhere.
Yeah.
What are we going to do with them? And I think that's absolutely critical. Thank you so much for bringing that up, and having that whole analytic component of who they are, where they are, what's their condition today, when can we send them somewhere else.
Yeah.
There's so many unanswered questions, I think, even now, about when could we transfer them back to a long-term care facility.
Yeah.
I know that one of my students is the director of nursing for a long-term care facility, and we don't have much going on in East Texas yet, but it's coming, and you can feel it. And that's a scary thing, because I'm not sure that's been discussed in the big picture as much as it should be.
No, I mean, you hear about, tragic human interest stories to, I think, try to get attention to the area, but certainly not as much from a response perspective in the news. But I would say, our organizations, again, largely being integrated delivery networks, they're part of a larger clinically integrated network in their community, have absolutely both leaned on their post-acute networks to sort of backfill, to make additional home visits, to be a part of the telehealth, telemonitoring workflows, but then also, again, thinking about them for these other standards, like reducing the documentation, putting the care plan on hold, focusing on key assessments, and then the PPE preservation as well has been critical in those settings. I think, though, that it's sort of you're starting to make that bridge into what we're calling the second surge,
Yeah.
that there is the surge that's happening right now. And Gregg could talk a little bit about the analytics maybe around that. But we're also seeing this second surge coming, this pent up demand for, chronically ill patients who have not received their routine care for fear of entering the healthcare system and being told not to. So it makes perfect sense. But they need care. Everybody else needs care. The backlog of primary care that's been put on hold, the backlog of surgeries that have been put on hold. I think this is going to be another place where, from an EPIC perspective, I've had a couple of thoughts. One would be, looking to our UK colleagues. We're not used to using wait lists in the United States. Maybe our premier academic medical centers are used to a wait list, but most of our organizations don't know what a wait list is and haven't really thought about triaging a chronic ill population or risk stratifying. So it's kind of pulling some of those pop health tools into this second surge idea to really decide how will you offer access and prioritize everyone else who will have this kind of pent up care demand post surge. So that's something that's been just starting, in terms of strategy. We're just starting we see that coming and just starting to think about it. But Gregg, thoughts from your perspective on the analytics, because I know we've got kind of a foot in the current surge analytics and then a foot in the pop health analytics world to try to drive those conversations. And Informatics, I think, is again right there at the data to information spark, to really try to help inform some of these decisions.
Yeah. I think every organization that we work with is obviously hungry for a better understanding of what their current capacity is, where they're at just within their organization, and using analytical tools, dashboards, and other reporting functions to be able to get there. One thing that we've kind of started doing across the whole of the EPIC community, or any organizations that are currently using EPIC, is starting to pull back some of the aggregate data to look at either benchmarked information, county by county, where we're at with ventilators, capacity, positive cases, negative cases, et cetera. And then starting to share those tools and that information with other either local or state or even federal organizations that are looking to start to consume or have insight into that data. Here in Wisconsin, we're actually sharing a dashboard, our COVID Pulse dashboard, with the governor's office, and they're using it to look at where we're at with what's being reported from organizations that are currently using EPIC, and what's the other data that they're seeing, to understand if we have a trend and if the trends are matching with what's actually happening at the health system level. I would also say that there is collaboration that's happening across the industry. This isn't a time to compete. We can't compete on saving lives. And so we have met with Cerner and Allscripts, some other, data forward groups like Health Catalyst and MITRE, as well as big health systems, Mayo Clinic, Hopkins, et cetera, to figure out how we can rapidly share any new knowledge that we've gained, collectively within each of these individual, maybe historically siloed organizations or entities. And then how can we kind of disseminate that more quickly, whether it's, predictors of disease, contributing factors, mitigating factors, or even severity of illness. There's some stratification that's happening across patient populations with all of those organizations. And I think this is really the time to be able to share and quickly disseminate any new knowledge that we've gained.
Yeah, the opportunities for research and gaining a much better understanding of our health inequities and how that's impacting all of us.
Yeah,
I think that's really something that's coming to the forefront. It's, yes, there's stratifications. We've kind of all known that intellectually, but now we're seeing, okay, guys, it isn't just about who's in your strata. Yeah. It's about everybody and how it affects everybody in the country now. So I foresee, that's my PhD side talking, a bunch of research
Yeah.
coming out of this that's really going to help us not only now and quickly, but really looking to the future of what do we need to do better.
Yeah.
So just as a wrap up, I want to be respectful of y'all's time. Is there anything else you'd like to share with our informatics community from y'all's perspective?
I think I have one thing, and then I think Gregg's got a couple things too. The one thing I just wanted to also underscore in that second surge coming is the recovery of our nurses. I think it's going to take a long time for our workforce to recover. So when we think about the cross-training strategies right now, both from a technology perspective as well as from a competency perspective, I think that's going to persist for a while. We're going to need to continue to think about backfilling for a while to not only get through the critical surge in terms of hospital care, but also this demand that's going to come for chronic illness, delayed primary care, and certainly then mental health. And I think it'll be, and I think it'll be mental health, certainly for the population, but also for our clinicians.
Oh yeah.
And thinking ahead about the resources needed to help them recover. But I do think from an informatics perspective, we're going to have to be almost as mobile as our workforce in terms of thinking about bringing ostensibly a new grad, maybe from ambulatory into the hospital or from a different setting back out to the clinics maybe. To help manage the recovery, if you will. So just wanted to underscore that because I think it speaks to the workforce for direct caregivers, but also for informatics, showing that same kind of nimbleness to really help the workforce stay flexible for the foreseeable future. I know, Gregg, you and I also talked about some silver lining we think that's here for informatics actually.
Yeah.
You want to talk about a couple of those points to help us wrap up?
Yeah, absolutely. I think to your point, Emily, the areas where we're seeing nurses needing to work that they haven't worked before, one nurse working in another setting, I'd say that actually applies to informatics as well, and that there is going to be a new set of competencies that informatics nurses will either be expected to have or that they need to develop, particularly around ambulatory care, developing and deploying like social programs around social behavioral determinants of health, behavioral health or mental health, and just pure play ambulatory care, as well as the population health that kind of is associated with maybe more traditional primary care. We do have organizations that have informatics nurses in those settings, but I think it's going to become a core competency of almost every informatics nurse to have some level of understanding of what those things are, whether it's telehealth or home device integration for home monitoring programs. I mean, those are just two brief examples that I think are new tools in the tool belt for informatics nurses. I think one of the other kind of silver linings is that informatics has been at the forefront of a lot of the change that's happened both within the EHR and just technology across the board that nurses are interacting with. And I think many of our organizations are really glad that they have a nursing informatics team right now. Maybe not every organization has a formal team, but now is the time that they can recognize it. So this would be my plug to informatics nurses to start cataloging the work. Don't be shy and definitely take credit for the things that you're doing, because you absolutely have a business case for the continued evolution of informatics and the need for informatics within an organization. So I guess that would be my kind of closing line for the silver lining of getting through all of this pandemic, but informatics being at the forefront.
I love that call to action for all of us, because I think you're absolutely right on. I think this is going to change the landscape of healthcare.
Okay.
And if we're not flexible and adaptable enough to change with it, it's not going to be good for us.
Right.
And we are very flexible and adaptable.
Mm-hmm.
We just got to but taking credit for it. I think that's one of our biggest problems, especially in nursing. altogether, is being able to say, that's our work. So anything else you guys want to share?
No, thanks for having us, and thanks for continuing the dialogue, you know, across different settings and customers and vendors. I think that's terrific. And I think, you know, as you look ahead, this second surge idea, you know, we're just starting to put our heads around it, but I bet in your membership there are some people who have some really great thoughts about that as well. But look forward to keeping in touch.
Oh, well, thank you guys, Greg, Emily, thank you so much for your time today. I truly appreciate it. And I know the people who watch this video are going to gain a lot of good nuggets of information and knowledge from it. So y'all take care, stay safe, and we'll talk to you next time.
Okay.
Thanks, Cheryl.
Bye.
Bye.
Bye.